and then eventually what we see in our clinic is what is actually sent to us down the road, down the line. So depending on what it is, it can be from your ankle, something simple as an ankle sprain, to something that requires surgery. But with some of the orthopedic surgeons I work with, there's different subspecialties of different orthopedic surgeons. There's I guess emergent would be trauma, which can see major accidents and things like so. But in our clinic, we tend to see a lot of the sports injuries. So it can be something as simple as open fractures, dislocations, which need to be reduced. But sometimes those are already seen by the emergency doctors as well.
All right. So obviously, I asked you to come on here. When we first met, you were telling me you were trained in emergency medicine, and you spent some time in emergency medicine in the hospitals, right?
Well, I actually did a lot of urgent care, right, which is one step lower. And a lot of the doctors who are trained in urgent care, they can mostly internal medicine and family medicine, and even these days sometimes can be staffed by nurse practitioners or even mid-level providers too. So there's a difference between most of those from that case to here, and as traditional ERs, that ERs are typically open 24/7, whereas urgent cares and those are not. And not only that, those patients who require more further attention need to be transferred to an emergency room setting for more appropriate care. Because a lot of what you may see in urgent care, yes, there's convenience to that, but some patients do not realize that some situations may be more emergent or need further workup.
All right, so since our target audience is athletic trainer, Jose's got a good question for you.
Any recommendations for athletic trainers dealing with broken bones?
Who are you going to start with?
Dr. Allenye.
I consider the athletic trainers to be the first responders. They see the athlete initially after the injury, and so their management can either make a bad situation a little bit better or make things worse. And what I mean by that, if you see someone that has a severe injury, the most important thing is to stabilize it. And there are too many injuries to say, well, how do you stabilize this versus that? But assuming that they've been properly trained is really to stabilize injuries such that no further injury can happen or is greatly minimized. And then the things that are emergent, for example, if there's a bone sticking through the skin, that needs to be handled a lot more aggressively than someone who just twisted an ankle or something, or sprained a shoulder. And so it's really letting athletic trainers know that their primary job is to make sure that no further injury happens to the athlete. And again, I assume I trust most medical professionals that everyone, as long as they've been adequately trained, knows how to handle any given situation. And so I see athletic trainers as very helpful, and actually probably saved my butt a few times too.
All right, so Dr. Lee, same question.
I absolutely agree with what Dr. Allenye has said. With me being on the field, a lot of the times we work very, very closely with athletic trainers. As far as emergency medicine situations, from that type of perspective, since a lot of athletic trainers are covering events as well, we try to do a lot of protocols and activate some type of protocol in which, before an emergency even happens, we already know what to do in certain situations and who to call. So if that means being prepared and having some type of response beforehand, that is absolutely what we should try to do to help with any situation which may arise.
I have a question for you. In the educational side, it's frustrating for me as an instructor with the students. The atmosphere that they're taught in is very calm, very collected. The patient, which is another student, is laying there perfectly still. Can you explain? And I don't want to necessarily focus on you, Dr. Allenye, but you probably see the scenario I want the students to see, which is the emergency room. What is the characteristic of an average patient that comes in with a traumatic injury besides the unconscious person that's there?
Sure,
are they crying? Are they screaming, scared? How do you deal with that from a physician side?
I think everyone deals with pain a little bit differently. I think I've seen people with open fractures or compound fractures with a bone is sticking through the skin. I've seen people be relatively calm with that, and then I've seen other people with that same and then there's people who twist their ankle and they're crying, I need a shot of morphine, I'm dying. And so I think you have to really cater your response to your patient. I think the one thing I always tell my patients, regardless of how much pain they present with, is to let them know, you're safe. We're going to take care of you. We're going to make you better. And so I think the advice I would give to any athletic trainer is, empathize with the person going through the injury. It's like, you're going to be okay. We're taking good care of you. Tell me it looks like, you twisted your knee, or this looks like it may be broken. We're going to splint it up for you. But don't worry, you're going to be okay. We're going to take good care of you. As long as you kind of keep their mind off of what's going on, it tends to calm down the situation. And then people, once the adrenaline starts wearing off, they start, absorbing more of what the situation is really going on. And most people will be able to get through the situation and be like, yeah, I got hurt real bad. But the most thing is for you not to freak out. If the patient is freaking out, you always have to remain calm, and that goes back to your training, and that goes back to your experience. When I first got out of school or residency, you have a certain amount of experience, but you don't have as much as you're going to get in what I consider the real world. And as that real world experience builds up for you, and you're in situations over and over again, you start to become a little bit more calm because you already know how to respond. Unfortunately, a lot of things we learn in school don't really apply in the real world. Because, like you just said, the fellow students, you're examining your student, they're nice and calm, but then they're, patients when you're taking care of them, dropping the F-bomb at you, and you just have to be, real mindful that you have to always remain professional and not get frustrated because they're going through a very stressful situation.
Dr. Lee, do you see that ever in the clinic, or is it pretty much filtered out by the time they see you, or do you still have these patients that you're spending more time on calming them down first, or is it?
Well, usually sometimes it's more of a miscommunication as to what they're being diagnosed with sometimes, and being able to communicate with the patient to explain what's going on. Okay, so a lot of times they can take a lot of time and be kind of stuck on one thing, but as long as you have a plan and explain to them where we're going with this, then they seem to comprehend a little bit more of what's going on. So, but from a clinic perspective, that's where I see it from all the time.
So could you talk about, I know, and I was athletic trainer clinically for quite a few years. I know my mindset when I'm running out on the football field, when you have triage or you have you get the phone call that there's a car wreck coming in, or when you were in urgent care, what is your mindset of how do you obviously you don't say, oh, we're getting an x-ray, my mindset was, what is the worst case scenario as I'm running out there? How do you, because you have a lot more resources, you have pharmaceuticals, you have x-ray, how do you kind of narrow down what your first step is and your second step is from a physician aspect?
Well, with a true traumatic patient, there's everything is very programmatic, and the reason it's that way is that you never want to miss anything. So they always teach you the ABCs. So when a patient first comes in from a traumatic injury, the first thing A stands for airway, is the person breathing. Because if the person's not breathing, it doesn't matter where they're injured, they're not going to make it until you secure their airway. The next thing after that is the B, which stands for their breathing. It's not so much about the fact that they're actually moving air, but how are they moving it? Are they moving very rapidly? Is one side of their chest expanding and the other side not? That's a sign that there may be some chest trauma and they may need some help with their breathing there. And finally, last thing is circulation, C, circulation. And that really goes to what's their blood pressure. Are there any areas that you notice that they're actively bleeding? You have to stop those areas because, obviously if they continue to bleed and continue to lose blood, it's going to lower their blood pressure and, it'll lead to more complications. And so that's, no matter who comes to the door, that's always the same process. So there's many times you have someone come in a car accident, they come into a trauma center, you start cutting off their clothes, they're strapped down to a board with a seat collar, and, they're saying, all I did was hurt my ankle. But we're going through our whole evaluation just because we don't want to miss anything, because you may have a broken ankle that's considered a distracting injury. And so you may have a C-spine fracture as well, but you can't really tell because your ankle's killing you so bad you can't feel pain anywhere else in your body. So that's why there's really, there is no freaking out or anything, because it's all prepared in your mind how you're going to treat this patient. And I would assume the same thing on the football field or any athletic field. You run out there, okay, is this patient breathing? Are they alert? Okay, can they talk to me? And especially in football, can they move everything? That's what I would think. I know you can think, I know you're answering my questions, but lift your right hand, lift your left hand, foot. Okay, I don't suspect a spinal injury or a very significant one at this point. That'll let me breathe a little bit easier, and then start going through kind of the secondary survey.
And I think what you demonstrated very well. Are you breathing? Okay, my stress level's high. They may not be breathing. Okay, they're breathing. Come down a level. They have movement. They're down a level. It's not a neck injury.
Right.
And then it's like, okay, there's this wave that comes over. Like, okay, it's just an orthopedic. And all of a sudden it's like, okay, we're going to do this. Can we get them off the field? If not, we'll do little things here. But yeah, I think you're right. But I mean, you see on TV, it's just utter chaos. They call it organized chaos. To me, it looks like chaos. But I was just curious. And do you see anything? I mean, in the clinic, obviously, they come in with a much more specific thing. But, obviously, you're probably not going to say, oh, we're x-raying. You have a thought process. What is your thought process going through, even on an orthopedic clinic situation?
Well, it has to be exactly the same thing. It's the same process. Maybe not as extreme, but sometimes a patient will come in with some type of injury, but really it's not that. So a lot of the things we see is shoulder pain, and it actually could be neck. So a lot of it comes to at that point when they're coming to the clinic, it's about going over your H&P, your history and your physical exam. Getting a good history as best as you can will basically dictate what you're going to do at that point, because they've already been stabilized now. So a lot of that will dictate what your plan will be from there. So getting a good history and physical.
I think they have a more challenging job from the standpoint of they have to trust whatever recommendations and what we said. And there's some camaraderie or collegiality in medicine, but there's also that little element of, I don't really trust what this other doctor said. I want to do my own evaluation. So it's when they're sent to a clinic, that doctor then has to make sure that whatever I did or a fellow emergency physician did was the right thing for the patient, because they're going to end up dealing with the long-term consequences of the patient. I did the initial stabilization. I put him in a splint, but if the patient has any kind of compression or any kind of vascular problem, they're going to have to deal with that long-term, not me.
All right, so Dr. Lee, kind of the same question is on the field. So, emergency situation, typically what I've seen with our doctors is they'll let us, the athletic trainers, go out on the field, and then they'll kind of slowly walk out there so that we're the one being, I guess, first in charge, and then they come up for support.
Right.
So talk to me about your program or your whatever it is for on the field, immediate care.
Sure. So it depends on where you've trained at, and it comes down to preparation. It all comes down to preparation. You want to know what's going on and who you're working with before you go out and start the game. So if it means knowing you've got EMS on site and you've got an ambulance, paramedics who are there with you that can help, then great. Also, as well as athletic trainers, are there athletic trainers for one team, both teams? Are there other doctors there too? So a lot of it's preparation before the game even starts. So you want to go and meet and greet and see who you've got available. A lot of times it just depends. It could be from middle school, high school, collegiate, professional level. There are different, I guess, set ways or protocols that are done, and there can be hand signals between the athletic trainers if the trainers have gone out there first. But those have to all be established beforehand, because you don't want to, if the doctor's on the sideline and they're not going to come out, but they're missing something, they want to be known or be alerted as soon as possible. Obviously, they're not watching the game just to watch a great game of some sort. They're watching a game to see what's going on. There are hits, there's certain plays, what action is going on. So, they're also being vigilant with their eyes. They may not be the ones with their hands immediately there, but then once they go on, they'll follow on the same what we would call standard of care with the ABCs, which may have already been initiated once they reach the field. Now, as far as who's out there, when you get on, get onto the field, it's typically the person who's got the most type of medical experience that will then have to determine who's giving what we call orders, or who's kind of directing what has to be done. So at sometimes it may not even be the physician. The athletic trainer may have much